How many?
118.
Right. Let's bring them
Good.
in.
Well, good evening, everybody. Thank you for joining this second in a series of presentations by the Chicago Medical Society, hosted by the Chicago Medical Society on the COVID-19 vaccine. I want to thank Dr. Butt and the Society for making this possible. And I want to thank the audience for taking time to participate in this very important topic. Tonight's meeting comes less than a week after the FDA's approval of the first COVID-19 vaccine by Pfizer, and on the day of the recommendation from the FDA panel to approve the second COVID-19 vaccine from this one from Mrna, both using an RNA technology. I said last week, it's truly serendipitous that science and technology has brought us to the point that we are able to rapidly develop a vaccine in a safe and effective way at a time that the world needs it the most. The goal of tonight and perhaps future programs is to provide you, the physician community, with the information that you need to inform your patients, yourselves, and your colleagues about the facts of this vaccine. As with anything that's in the news, there are a lot of legitimate questions. There are some myths and some frank misinformation. We want to address all of those. We want to address what are some very good and difficult questions, and the panel has a short presentation based on some of the questions that came in last week. And then we also want to address some of the myths that are out there, as well as some of the misinformation. And hopefully in doing all of that, it will not only inform you, but I hope it will make you ambassadors, not only to your patients, but to your colleagues, to spread factual information related to this important topic. We're going to have some short presentations, and then our panel, Dr. Vishnu Chundi, Dr. Daniel Johnson, and Dr. Edward Lin will give their formal presentations, and then they'll answer a Q&A, some of which have already come in, but we'll be following a chat to look for other questions that may come up during the meeting. Just to familiarize yourself, I'm Steve Andra. I am a neurosurgeon by training. Many of you may remember me from my time at Northwestern, where I was program director for neurosurgery, then chief medical officer at Northwestern Medicine. I was also at the White House, where I had several jobs that included co-chair of the National Science and Technology Council. I was also chief medical officer at HCSC, and I'm now a consultant in Washington, D.C. Dr. Vishnu Chundi is a member of this panel. I introduced him last week. He's a specialist in infectious diseases. He's on the COVID-19 task force chairs the COVID-19 task force for the Chicago Medical Society. He has a broad experience in infectious disease and is respected and known around the world for his expertise. Dr. Daniel Johnson is a nationally recognized pediatric infectious disease specialist. He is a member of the fairly newly formed COVID vaccine scientific working group of the Chicago Department of Public Health. And I think all of you know Dr. Ed Lin. And Dr. Lin is a trustee of the Chicago Medical Society, former president, interim chair of OBGYN at Rush University, my alma mater, and previously a chair of OBGYN at Advocate Lutheran. With those brief introductions, I want to turn to the panel and Dr. Chundi, and after the three of them give their formal remarks, we hope to answer many of the questions that you've sent in and we'll be sending in during the course of this evening. Thank you very much, Dr. Chundi.
Thank you. There was a small chat that there's no volume. I believe, Dr. Butt, you can hear me, correct?
Yes.
Okay, perfect. Can I go to the first slide, please?
And if they missed my introduction, all the better for them.
So I think from the goals of the town hall, I wanted to go through a few things which will be covered by the panelists. So understand how mRNA vaccines work. We want to talk about the safety profile of COVID-19 vaccines, the efficacy of the current vaccines, the expected side effects of current vaccines, talk about pregnancy and lactation, because that's a major topic about for vaccination in healthcare, where 75% of the healthcare, 70% of the healthcare force are women. Trusted messengers. I think as physicians, we should all become what are called trusted messengers. That means people who are vaccine advocates, and these may be physicians, celebrities, social influencers. This would help a great deal in spreading the message correctly, so we have high vaccine acceptance rates. And it's really important so we can take our masks off and live lives the way we used to remember, which seems so far away. And then be comfortable taking the vaccine and giving it to your family. I think when you do that, you become the strongest advocate. One of the important aspects of all of this is the most trusted people in society about healthcare are doctors and nurses, and that physician-patient relationship is a bond that has been there for millennia, and it should be, and it's something that we need to leverage for the good of our patients and society. Next slide. So these are two patients I've seen, and these are illustrative cases to talk about what COVID-19 does as natural outcomes compared to vaccine related side effects, because everyone is worried about vaccine related side effects. So this is a 42-year-old gentleman we saw earlier in the year, had basically a short course of fever, cough, well-controlled diabetes. He was diagnosed with COVID-19. He progressed to a high flow nasal cannula, to a BiPAP, and then intubation. Could not oxygenate him. Eventually got ECMO, had barotrauma, including chest tubes, mediastinal air, and then he eventually was transplanted, a double lung transplant. That is not it's not an unheard of thing happening. We're seeing this more and more. The second person, quickly, is a 65-year-old gentleman who had COVID-19, sent home from the emergency room. He felt fine. And 4 weeks later, he became progressively short of breath, had difficulty breathing. He had extensive workup, which was all negative. He was found to have significant pulmonary fibrosis and now is on a constant 30 liters oxygen. And we're seeing this more and more and more as more people have gotten infected with COVID-19. So that myth that's out there that, oh, it doesn't really do much except for to old people is not true. Today, in an opinion piece in the New York Times by the incoming director of CDC, clearly states, and correctly so, that young people are disproportionate. They have a higher mortality as compared to last year, and this is presumed to be COVID-19 in the New York area. And this is Dr. Walensky and three other folks. And you should read that op-ed, because it really kind of hits home that it's not just old people and sick people that are dying, but a significant number of younger folks who are also affected. Next slide. So what is mRNA and what does it really do? So mRNA stands for messenger RNA, and messenger RNA basically makes the proteins that you need. Okay. The problem with using messenger RNA to do stuff is you have RNases in your body, and immediately if you put it into your body, it basically lyses the RNA. So the magic potion that BioNTech and Moderna came up with are lipid particles that allow transport of the mRNA to the target, which are the muscle cells where the Golgi apparatus take over, and make a tiny portion of the spike protein. In January, when the Chinese published the sequence of coronavirus, within 48 hours, NIH recognized the spike protein and the part of the protein which was antigenic. And within 63 days, the vaccine was produced. Now, how did this happen? It didn't happen in 63 days. It actually took more than 15 years. And I just wanted to go through this to kind of break up that myth that this was an immediate thing that just kind of happened and rushed through. Next slide. So serendipity. So you had a confluence of factors which were beneficial. And there were two companies that were making a vaccine for Zika. Remember Zika? It was supposed to ruin the rest of the world. And magically, Zika went away. It was in Brazil. It started out in Oceania, actually was transported by truck tires in transglobal trade. And the virus, Zika virus, was carried by Aedes aegypti, and it caused birth defects, massive birth defects in Brazil. And so these two companies, BioNTech and Moderna, came up with a mRNA technology for these vaccines. And they were highly effective vaccines. But then they went to give Zika vaccine, the Zika disappeared. And the reason why it disappeared, interestingly, was because of another virus, which was dengue. And dengue has the same mosquito vector, and they occupy the similar sites in the hindgut of the mosquito. And when dengue came there, it preferentially infected people, and lo and behold, no more Zika, which is fascinating from a biological perspective, but not good for these two companies, because now they had a lot of vaccine methodology to make vaccine and no one to sell it to. And lucky, and suddenly we end up getting this novel coronavirus, SARS-CoV-2, and we get COVID-19, and they had the platform built already. And all they had to do was, and they had the sequence done, and they knew the antigenic portion of it based on the NIH, and they were quickly able to find an mRNA piece. And because they had the delivery, they were able to put it in there and create the vaccine and get it into a person within 63 days of this virus coming out. So it was not a short sequence. This was 15 years of research of using mRNA. And then the NIH, which had already built up a vast network of research trial experience, leveraged that to conduct a trial in a very rapid manner where we have safety data that's equivalent to any other vaccine that's previously been tried. We have 43,000 people with the Pfizer vaccine, and we have over 30,000 people with the Moderna vaccine, which is sitting in front of the FDA today. And the federal government, to take away the risk, basically bankrolled it, said we will take the downside risk for the vaccine and buy it so you can produce it as soon as you think the vaccine works. And so the production started taking place at the same time the approval process and the trials were taking place. And so the federal approval, the FDA approval process and the safety requirements were unchanged for these two vaccines. It's the development process that was able to be done much quicker. Dr. Johnson had a slide on that, but I wanted to take you to the backstory to say, this is how it happened. Next slide. So as my former mentor, Bob Weinstein, said, it's good to be smart, but it's better to be lucky. These companies were smart and lucky. So there you go. Safety. The Pfizer vaccine, 43,651 participants. The follow-up was, actually the follow-up was it was 2 months follow-up, 16 weeks follow-up eventually. And you had no major side effects, which was remarkable. And then in Britain, they had 2 anaphylactoid reactions. And I think yesterday in Alaska, there was 1 more reaction in a healthcare worker. And the 2 people in Britain did have a prior history of anaphylactic reactions. The healthcare worker did not. No one was seriously injured. And the injection of epinephrine saved everybody. So the current recommendations are to watch people for 15 minutes, which is a normal recommendation, and for people with severe reactions, to watch them for 30 minutes. The Moderna vaccine had 30,420 participants, no major side effects again, and the efficacy was very high at 94.1%. And the primary endpoint of prevention of COVID-19 was met, and the efficacy was very good. Secondary endpoints, including hospitalizations, and much more importantly, deaths were averted. There were no deaths in the Moderna trial where people received vaccine. Next. So the 2 different vaccines. And so you can't intermix these things once both the vaccines are out. And unfortunately for us, the other vaccine candidates from GSK as well as Sanofi have hit stumbling blocks, and they don't expect to be out till at the earliest, late 2021 and probably 2022. The other vaccine, which was the Oxford vaccine, the trial had several issues with it. So the FDA, they're not ready to submit to FDA yet. And so that's also going to be delayed. So for now, as far as I'm aware, these are the 2 vaccines that we're going to have for the near future, for the next 3 to 4 months. The 2 vaccines are different. They have a different carrier nanolipid particles. So the Pfizer vaccine requires ultra cold storage, so minus 70 degrees Celsius. So this is really better for hospitals and urban areas. And it's good for 5 days once you get it to minus 20. And the dose is 30 micrograms, so different dose and different schedule. So day 1 and day 22. The Moderna vaccine is stable at minus 20, which is much easier to do in hospital clinics and in exurban and rural areas. And it's really a better vaccine for private doctors' offices and areas where you don't have minus 70 degree freezers. Because when you get that cold, the handling of the vaccine, everything else becomes much more laborious. Next slide. So the comparison between these two vaccines, both the Pfizer and the Moderna, they're very safe vaccines. I lost my slides here. Where did they go? I lost the slides. What happened here? There we go. So very safe vaccine. The major side effect that they're having, which is the reactogenicity, because you're actually making antibodies, is local pain and fever, and that usually lasts less than a day. And the fever is, and the reactions are worse at the second injection when you have more immune reactivity. There's also regional lymphadenitis, and that has to do with basically your germinal cells, the germinal areas in your lymph nodes expanding. There were Bell's palsies noted in the Pfizer vaccines. There were 4 in the Pfizer vaccines, and the Moderna had 3. The Moderna vaccine, interestingly, had, what is going on here? So the Moderna vaccine had more local reactions, headache, and interestingly, more lymphadenitis, axillary adenitis, significantly more than the Pfizer vaccine. Still a very safe vaccine, but a little bit higher side effects. The other issue with the Moderna vaccine was it was a little less effective in people over 65, 86% versus over 90% for the Pfizer vaccine. Next. Next slide. Oh, there you go. Can you go back one? I think that was, okay. So the indications for the Pfizer vaccine is greater than 16 years of age. The Moderna is 18. The doses are different, as we talked about. And there's no difference in efficacy based on race, okay? So it worked equally well in Latinx, African Americans. So it clearly doesn't matter what race you give it to. There was also a difference in when the protection starts. The Pfizer vaccine, the graph shows that your protection started 10 days after the first doses, whereas the Moderna, you really had to wait out till about 28 days. Next slide. And this basically shows the Pfizer vaccine on this side, where you see the takeoff with the red line and the blue line being placebo. This is around day 8, day 9, where the efficacy starts increasing. And the Moderna vaccine goes all the way out to about day 30 before you get the second dose, and then you see the uptick. So you're going to have to wait for approximately 6 weeks before you get good protection with these vaccines. And the efficacy is equivalent to about 95%. Next. So what are the known knowns? I think this was made famous by Rumsfeld. Vaccines are safe. Both these vaccines. Natalie, you have to mute. Thank you, Ron. So these vaccines are safe. They're effective. They have a complex cold chain. They're both 2 doses and they cannot be interchanged. And basically, we brought about 300 million doses, of which you're going to be able to give 150 million people vaccine. So you're still going to have a shortfall of vaccine. Next slide. So the known unknowns. So how long will the vaccine protect you? We have experimental data that it says it'll protect you for a while. And these vaccines will, will it prevent transmission? We don't know yet. We think it will. The Moderna vaccine excitingly seems to decrease transmission, but that has not been shown. We will know within the next 8 to 12 weeks because there's so much COVID in the community. Use in children, it has not been used in children, but that's starting. The trials are starting. And use in pregnation and lactation, that Dr. Lin will talk about. And long-term side effects, most vaccines, especially these small protein vaccines, the side effects occur within 6 weeks of giving the vaccine. And these have been unbelievably safe vaccines. If you ask the infectious disease world if they could add a 95% efficacy with this amount of safety profile, you would have blown them over with a feather. This is just the results are a grade which is A+ for both of these vaccines. Next slide. So what are the unknowns? So you don't know. So we have two vaccine reporting systems, vaccine adverse event reporting systems. And then we have vSafe, which is an app that CDC developed. We talked about that last week. And then I just want to talk a little bit about Guillain-Barré, because everybody talks about Guillain-Barré with vaccines. This is because of the swine flu, which happened in 1976, I think 76 under Jerry Ford. So basically, if you get influenza vaccine, the incidence of Guillain-Barré is about 1 in a million. Natural influenza causes Guillain-Barré at about 17 cases per 1 million, 17 cases per 1 million population. So across the board, natural infection has a higher risk of having side effects and having adverse events compared to vaccine-related events. Vaccine-related events are not zero, but they're significantly less than natural infection, whether you take measles, whether you take mumps, whether you take pertussis. And we can address this later on in our question and answers. Next slide. And so I will leave this to Dr.
Johnson.
Lin. Dr. Johnson, are you going to talk about this? Perfect. Okay, I'm done.
I'm happy to talk about this.
Oh yeah, go ahead. Yeah.
Or Dr. Well, great. So what you see before you is a schematic that shows how mRNA vaccines work. And we should think first, as Dr. Chundy mentioned, that mRNA vaccines have been around for about 20 years. When they first were created, what was being done was the injection of naked mRNA. And it was found to be quite immunogenic, but it also was found to be rapidly destroyed. So you had to use extremely high doses in order to be able to get some of it into the host cells. The end result was that it was much more reactogenic. So about 10 years ago, someone got the bright idea that you could take the mRNA and code it. And the choice was to use a nanoparticle that was composed of a lipid membrane. It's actually 4 different lipids that compose the membrane. And by putting the mRNA inside of that membrane, it then protected it from the host immune response, and then allowed the mRNA both to be used in a lower dose, but also for it to be able to make it to the host cell where it's engulfed, as you can see in an endosome. Sort of think about it as the candy coating of M&Ms, where the candy coating is protecting the chocolate in order to make sure it gets in your mouth. And what the lipid bilayer is doing here is making sure that mRNA gets to the host cell. Once the nanoparticle is engulfed, it then intracellularly, the lipid layer is destroyed, revealing the mRNA, which then is able to do its work. Where does it do its work? It does it in the cytosol. So this does not enter the nucleus. It therefore doesn't get incorporated into the host's DNA. I know there have been many questions by people saying, well, what about if you have reverse transcriptase? And of course, reverse transcriptase comes from HIV and other viruses that may contain it. But of course, that reverse transcriptase is designed to replicate the viral DNA that's required. So it takes RNA and produces DNA, but it doesn't do that with any RNA. It only does it with RNA that's unique to the virus. As I think everyone is well aware, COVID, SARS-CoV-2, does not use reverse transcriptase. And so, of course, you don't see production of the RNA into DNA. You just see production of protein, which is what the intent is of mRNA. And the mRNA then moves to the ribosome in order to produce proteins. Those proteins then are either incorporated into the host's membrane, to host cell membrane, or they're
Dan, you are muted.
Sorry about that. When the mRNA then is injected, it goes into the muscle cell where it's incorporated, as I've described, or it's engulfed by antigen presenting cells. And then with that, it then, next slide, rather just click because I want to show the other part of this slide. Thank you. And then what happens is you see the response of the host is a mixed response of both T cells and B cells. And this perhaps is part of the reason why the vaccine is so effective. We don't know the correlates of immunity for COVID. And it could be that antibody is important, but it could just be that antibody is merely a marker of the host's immune response. And it may be that T cell response is as important, if not more so. And the beauty of mRNA is that it leads to a mixed response of both T cells and B cells. Next slide.
And I think that next we're going to Dr. Lin, and thank you, Dr. Johnson, for the genetic refresher that God knows I need, and I'm sure many of us need. It's been a while since medical school and the last time I looked at that, so thank you. Dr. Lin. And you may mute yourself there.
Good evening. May I have the first slide? So again, we're going to cover 3 points when we're talking about the reproductive age woman. We're going to be focusing on the woman who's pregnant, the woman who's lactating, breastfeeding, and women who are attempting to become pregnant during this time period. Fortunately, the American College of OBGYN followed within 48 hours after the Society for Maternal Fetal Medicine issuing their opinions. And what you're going to be seeing in this portion of the presentation has been taken from this opinion. And I want to go back to the point that Dr. Chundy was making, is that vaccines are one of the greatest public health achievements in the 20th century. And before the widespread use of vaccine, people routinely died from infectious disease. And many of these have actually been eradicated thanks to robust immunization programs. Again, this is a statement that ACOG is trying to emphasize, and this is, we hope is communicated to our patients, is that even though this was warp speed, and this was a rapid development of these vaccines, there was no safety standards that have been relaxed. And actually additional methods of monitoring safety to track patients and monitor them has been included in real-time assessment because of our communication technology. We can expect an influenza-like illness as we described. This is a normal reaction, and I like to tell patients that this means that their immune system is reacting to the antigen, and that's good. I want to emphasize and re-emphasize, and I'll say it a third time, COVID-19 vaccines cannot cause the infection. Unlike other vaccines, which use attenuated virus or even some, the older killed viruses, this is simply a segment of mRNA that allows the host cell to be programmed to produce a couple of proteins which are located on the spike portion of the COVID particle. And therefore, it makes it difficult, if not impossible, for the virus to attach and behave like a virus. We do have vaccines historically that have been given to pregnant and lactating individuals for decades. Influenza vaccine is an example. And again, we like to use that famous balance of benefit versus risk, and which is worse. And in the case of this infection, as in many, the risk of infection is far more deleterious and dangerous to our patients than the theoretical risk from the vaccine. May I have the next slide, please? So these are the recommendations that ACOG has made. The recommendation is the vaccine should not be withheld from pregnant individuals who meet the criteria for vaccination based on the ACIP recommended priority groups. So people that are in group 1, people who are involved in caring for infected patients. We're talking about nurses, we're talking about physicians, respiratory therapists, and the whole team approach should be offered this vaccine, and it should not be withheld. Now, obviously, we don't have randomized controlled trial safety data because pregnant women were not included in the study group. We do know that women became pregnant while participating, and we are waiting for further analysis of that data. But ACOG is recommending that pregnant individuals should be free to make their own decision in conjunction with their clinical care team. So I'd like to go to the next slide, please. And this is what should be considered. The vaccine should have, individuals should be offered the vaccine, as we mentioned before, and explained about the fact that we have a paucity of data. But because of the wonderful safety profile that we've seen, we don't have as much anxiety. This is not necessarily going into something totally unknown. But the patient has to ultimately make the decision, just like anything that we do therapeutically. So things that you can factor into the balance is what's the level of activity of virus in the community? We know the potential efficacy of the vaccine is phenomenal based on the study of over 80,000 people. And we also know the risk and potential severity of maternal disease, including the effects of the disease on the fetus and newborn. And when we look at the mom, we realize that some of our patients have become very ill. There is measurable mortality, and like many situations, pregnant women often do not handle exogenous infections very well, possibly because of their innate immune paralysis during pregnancy. We don't think the vaccine crosses the placenta. There's been no evidence. It's been recovered in placental tissue, but whether it's active and potentially infectious is something that we don't know. And we're waiting for more information about the safety of the vaccine in the pregnant patient and the fetus. Next slide, please. When it comes to lactation, ACOG again recommends the vaccine be offered to lactating individuals similar to non-lactating individuals when they meet criteria for receipt of the vaccine based on the prioritization groups as we had talked about before. So when your number or your patient's number comes up and they're ready to receive their vaccine, we're highly encouraging patients who are lactating. We understand the lactating individuals, just like pregnant individuals, are not included in most clinical trials, but we feel that the vaccine should not be withheld. Now, there's theoretical concerns regarding the safety of vaccinating in lactating individuals, but clearly the risk of infection outweighs it. And for that reason, we don't feel there's a need to avoid initiation or discontinuing breastfeeding while a patient is receiving the vaccination protocol. Next slide. Now, reality is that we have a very large number of reproductive age females who will be exposed to COVID. And therefore, we strongly encourage individuals to be vaccinated who aren't pregnant. But even if they're contemplating getting pregnant or they are actively trying, we don't discourage them for receiving the vaccine. It's not necessary to delay pregnancy after completing the vaccination. You know, for instance, we're used to rubella vaccination where we will advise strongly that until there's a period of time that we don't advise the patient to conceive. This is a different type of vaccine. Remember, we're not giving the patient virus. We're just stimulating the immune system to make antibody and have T-cell reaction to the protein. If an individual becomes pregnant after the first dose of COVID, we encourage the second dose. Now let's assume we have a patient that becomes pregnant within 30 days of receiving the vaccine, and we're actually asking you to speak to your patients about enrolling in the VSafe program, which is a program the CDC has rolled out, and it's on the CDC website, and we'll explain in detail. But the patient will actually receive a smartphone app that they will be giving information, because we're trying to learn, you know, as best we can, you know, as to whether or not there's any issues that come up. So far to date, there haven't been any to make us concerned. So I have rolled through a lot of material. Again, I encourage you to look at the ACOG website. It's available, as well as on the CDC. And we hope to maybe be able to post this material you know, for your references moving forward on the CMS website. And we're planning to develop a handout educational piece so you can use this when you're talking to your patients. I believe we have completed the prepared portion of.
Right. Thank you, Dr. Lin, Dr. Johnson, Dr. Chundy. This is a great week. I've got a lot of questions that have come in and some that were sent in before. Here's one coming right now. Okay. There's been a couple of people that wanted Dr. Johnson to go over those two slides because the sound cut out for part of it for many people. Dr. Johnson, could you do a quick reprise of slides 13 and 14? And if the staff could go back to slide 13, because this actually answers a lot of the questions that came in on genetics. And so it's probably worth a couple of minutes. Then we'll have about 20 minutes for other questions that have come in, and I will get to as many of those as possible. I'll ask the panelists to keep their answers as succinct as possible so we can get to many questions. Hard to do for clinician scientists, but we'll give it our best shot. Dr. Johnson, do you want to do a quick reprise of this slide? Sure. And the next one?
Sure, happy to do so. Thank you, Natalie, for pulling that back up. So what you see here is the nanoparticle acts as a delivery vehicle for delivering mRNA to the host cell. The reason why a nanoparticle is used is because it protects the mRNA from being attacked by nucleases that circulate in the host and allows then the mRNA to be able to get into the host cell. Once the nanoparticle is in the host cell, the outer layer, the lipid bilayer, is stripped away. It degrades, and then the mRNA is taken up by the ribosome. There's been a lot of concern by people about whether or not the mRNA can be made into DNA, and of course, fortunately, the answer to that question is no. There have been several people who have asked about whether or not if you have reverse transcriptase, such as an HIV infected person, could they take this RNA and produce it into DNA? And again, the answer there is no, and it's simply because reverse transcriptases work specifically with particular pieces of RNA, and there is no reverse transcriptase associated with this virus, and therefore we don't have to worry about the RNA being templated into DNA. Also, the RNA only stays in the cytosol, and of course the host DNA is in the nucleus. Once producing those proteins, it then moves the proteins to the cell membrane or is secreted and able to be taken up by antigen presenting cells. So if you go to the next slide. Thank you. You'll see here that the way in which the vaccine is delivered is through an IM injection. And so the muscle cells will take up the mRNA, and the antigen presenting cells can also take it up, as well as handle protein. And then what happens with the cells is, again, if you'll advance to the second half of the slide, you can see then that the muscle cells as well as the antigen presenting cells then present the antigen to T cells and B cells, which leads to then production of a full immune response. And we don't know the correlates of immunity for COVID. What we do know is that this vaccine leads to a robust response amongst T cells and B cells. And it could be that the T cell response is as important, perhaps even more important, to prolonged immunity against the virus. And so thankfully, this vaccine will produce both. So that's a very short recap of these two slides.
And thank you, Dr. Johnson. And with that recap of a full medical school course into 2 minutes, we'll go to some other questions and answers. There were a lot of questions about genetics and also pregnancy and lactation. I'm not going to address those because I think those have been answered well by the panel. But of course, offline, I know the Medical Society is considering doing a blog where your colleague experts can answer questions in the future, and some of the ones that have come in. The Medical Society will rebroadcast some of these sessions. And so you can go back to that and also interact with people down the line. Let me turn to some of the questions about allergy and side effects. One of them is, it's been recommended that a person who carries an EpiPen should not get the Pfizer vaccine. How about people with seasonal allergies, asthma, or severe food allergies and anaphylaxis to those?
Dan, do you want to take that one?
Go ahead, Dr. Chandy.
So there's a formal recommendation for food allergies that they not be treated like anaphylactic to injectables. People with severe allergies like that should take the vaccine, and the observation period can be lengthened for 30 days. If you're otherwise healthy and you get the vaccine, like any good practice, you should watch the person for 15 minutes in your office. Otherwise, 30 minutes for the rest of the folks. If you have anaphylaxis, you should, current recommendation is not to give the vaccine. Correct, Dr. Johnson?
Well, it's not an absolute contraindication, but it is a recommendation that you be very careful with that person and recommend that they consider not receiving the vaccine at this time if they've had anaphylaxis to any component of the vaccine. Of course, that would be an absolute contraindication. That if they've had anaphylaxis to an injectable, that they only receive the vaccine in a controlled environment where there's the ability to be able to respond to anaphylaxis should it occur. So the only absolute contraindication would be if you have an allergy to any component of the vaccine. And remember, the nanoparticle is composed of 4 different lipids. And so in theory, then someone could be allergic to any of the components of the nanoparticle.
And for whatever it's worth, I have 3 daughters. One of them has severe anaphylactic food allergies. And I've gone through this with her, and when she gets her chance, she's going to get the vaccine and just be watched closely. So I can't give a more personal validation to that than my own daughter. There was a question related to allergies and Bell's palsy. Is the Bell's palsy the same temporary, number one, and number two, if someone's had a Bell's palsy in the past, should they or should they not get the vaccine?
So I can handle that one.
Thank you.
So first, Bell's palsy has been highlighted, but from both a statistical point of view and therefore a safety point of view, the incidence of Bell's palsy is not meaningful. First, it was no higher than the general population. So you would have expected at least this number of episodes of Bell palsy in either one of the groups. So at this point, it does not appear, and there's no reason right now to believe that Bell's palsy is caused by the vaccine. And therefore, I would say, and certainly the FDA and ACIP concur, that Bell's palsy is not a contraindication or even a precaution for receiving the vaccine.
In sort of the last in a series of questions on this, then we'll go to another set of topics. There's been a lot of questions about autoimmune reactions, the possibility of that being an increased risk with this, and is any HLA type a concern for autoimmune reaction?
So not as far as we know. There isn't any HLA data, but then I'll also point out there haven't been any cases of autoimmune-based disease associated with the vaccines to date. So at this moment, there's little reason to be concerned about it. The reason why, though, there was special emphasis on autoimmunity is because when mRNA vaccines first appeared, they were being used in very high doses of naked mRNA. And because of such high doses, more than likely, there were some episodes of autoimmunity associated with their testing. But that has not been seen in the case of nanoparticles, mRNA-based vaccines.
Thank you. Moving on to a slightly different set of topics. Dr. Chandy, can you be an asymptomatic carrier post-vaccine? So you're now immune. The studies were prevention of symptomatic disease. What data do we have about asymptomatic carriers by someone who's vaccinated, and can they infect other people?
So in measles is the most infective sort of viral illness out there. It's a great model. Even if you're vaccinated against measles, you get exposed to someone with measles, you may carry the measles virus for a short period of time and not become symptomatic. But you can certainly infect other susceptible hosts to it. These vaccines this is something that's actively being looked at because the hope is that you do generally secrete much less virus when you're vaccinated. So your ability to infect somebody depends on the amount of virus and the activity that you're doing. So singing, loud talking, you spread the viral cloud around you. But if you're vaccinated, the viral cloud would be much smaller. And so you should have a lesser amount of spread. And the R naught, which is the holy grail of epidemiology, it seems like right now for transmission, should get less than 1. So once you're transmitting to less than 1 person, the epidemic should die away and the pandemic should die away. So the vaccination will probably be your best bet to decrease the amount of spread. It is unknown whether you're still going to be infectious. The hope is that you're not going to be as infectious, so we're going to all wear our masks until the incidence of disease in the community is low enough where public health officials will say, we're good. Any comments from Dr. Johnson or?
How about this? How about if you've had COVID-19 in the past, do you still need to be vaccinated? And do you need an antibody test?
So the ACIP guidelines say no antibody tests, and certainly the infectious disease world agrees with that. The guidelines currently say after 90 days after infection, you should get the vaccine because your immunity does wane. And the vaccine immunity seems to be very durable, probably, and in experimental models seems to be more durable than the natural immunity. So this whole concept that, herd immunity by natural immunity being superior is not true.
But because we don't know the correlates of immunity, we don't know the predictive value of antibody testing. And so that further is a reason why there's no value to it. We also don't know the duration of protection of the vaccine, nor do we know the duration of protection from natural infection. So as a consequence, we are recommending that people get vaccinated even if they've had COVID in the past. The 90-day window is because we think that almost universal protection with following COVID infection lasts 90 days. It may last longer for most people, but there are some people where 90 days appears to be at least a magic number in terms of antibody. But would there be harm to you getting vaccinated in under the 90 days? There is no data to suggest that it would be harmful, but we think you should hold off on vaccination in order to let someone else get vaccinated in that 90-day window, and then you get vaccinated thereafter.
Thank you very much. Something in the last question in this sort of category, I feel like I'm Alex Trebek on Jeopardy. And the last one in this category is what is the relates to durability. Do we know anything about the mutagenicity of the virus and how long this vaccine is likely to be effective?
Yeah, actually, this virus is not. You read about it and see everyone reports about it. But this virus is a very large virus. It's a very stable virus, and it has mechanisms to read and correct mutations in this virus. It's not like influenza, where in one person you have so many mutations because of the neuraminidase. So this virus, even though it mutated to a different strain, which produces a little bit more virus and produces, and it's probably a little bit more infective, it is not an important mutation for antigenicity. So this virus is very stable, and it's probably stable for a fair amount of time. We will know as the duration of time goes on and we collect more and more of these little offshoots, the little clades of this virus. It's not HIV, it's not influenza. The coronaviruses are fairly stable. It's a beta coronavirus, which are more stable than alpha coronaviruses.
And the spike protein has shown great stability. So for right now, we of course can't predict the future of a new virus, but so far that spike protein is hanging in there and we're taking advantage of it.
Great. Now moving to another area, the sequence of vaccination, 21 or 28 days, how important is it that you hit exactly that time after? If you're a day off, are you back to square one?
I can handle that. The answer is no. First, the recommended window for the Pfizer vaccine is between 18 and 25 days after the first dose. But ACIP and the FDA, as well as the CDC, have indicated that if this is what would be ideal. If you get the vaccine later than that, your second dose later than that, the presumption is it's still going to be efficacious. we don't have data on that, so we can't be 100% sure. But ACIP, CDC, and the FDA have all said that you should not then restart the dosing, that you should assume that even if you got it late, that it still is efficacious.
Thank you. And the last question in this category is a question about the availability of practitioners outside of the hospital systems. How can they get in the queue, so to speak? Because many of these initially to practitioners are being delivered at the hospital. If you're a practitioner who's not affiliated with the hospital, what can you do?
Candace Robinson last week intimated that the Chicago Department of Public Health, as well as IDPH, has a plan in place for these non-affiliated practitioners. And that will be rolled out after this hospital rollout is completed in the next few weeks. So they will be able to get vaccine, and the exact how much vaccine and all that is very fluid. Actually, I was talking to them last night to figure out how we can address this, because I knew this is a question that was going to come up. But right now, the amount of vaccine that's being supplied is changing. And you want to make sure the people who got vaccine today will have a dose in 18 to 25 days, like 21 days. So more news on that by CDPH and IDPH, and we will update it on our website and as soon as we get more concrete data.
Thank you. And then a couple of kind of random category questions. But one is, if you have a history of autoimmune disease, is that a relative contraindication or something not to worry about in terms of getting vaccine?
Dr. Chen, do you want to handle that?
Autoimmunity is not a contraindication for this vaccine. I keep getting these questions all the time because people are afraid that they're going to have reactogenicity or from this or flare. We have now, like we said, 43,000 on one set, 30,000 of which half got vaccine, and it's been very safe. There was a question in there about HIV. There were a couple of hundred patients on the Pfizer side, 150 or so on the Moderna side with HIV, and they've done quite well. But that's not a large enough data set to go out and say definitively, this indicated in this population. That will be known probably in the next 4 to 6 months as we're rolling out this vaccine to tens of thousands of people. So that news will come. We'll know fairly quickly. Dr. Johnson, you talk about the short duration for follow-up of these patients, but 6 weeks seems to be a pretty good time to know if you're going to have significant adverse events from this vaccine.
So, we're going to go for just a few more minutes since we started a few minutes late. There was a question about what lipid. Do we know what lipids are in the nanoparticles? So people can take a look, at least get a little bit more informed opinion about allergy.
Yeah, I can tell you that off the top of my head, they're complex names, and it's difficult for me to be able to say them without reading them in front of me, and I don't have it pulled up. But it's relatively easy to Google that. So I would suggest you just go ahead and do that. Or if you, what I can do is send it to the Chicago Medical Society, and then the society, I would imagine, can post that.
And with 2 minutes left, I just have one last category of questions, and at least I'm through with what I have, and that is, how representative were the populations in these studies? Is this broad, number one? And number two, there was someone commented there was an MIT paper from December 2nd that suggested this was not as effective in people of Asian descent. So questions about population and effectiveness.
The population studied were broad. From minorities were well represented in this study. And Latinx, African Americans were all represented nicely in this population. and as far as the Asians, I did not read that. I would like to look at that. I can't believe there's numbers enough to make definitive statements of, immunogenicity on on small subsets. Dr. Johnson, would you comment on that?
Yeah. So the total efficacy of the vaccine for this particular data set showed about a 94-95% efficacy rate. And of course, there were some differences in the median values for different populations, but the confidence intervals all spanned similar ranges. And so this is the reason why it's easy to say that there was no significant difference across populations. If you look at the data on the Pfizer vaccine for Asian populations, it was in, I believe, the mid-70s for the mean. But again, the confidence intervals were broad enough and there's no statistical difference across populations. So I would say for the time being, it's still a reasonable statement to say that there's no difference. The MIT paper tried to use a predictive model and artificial intelligence to look at some of the factors, and they felt that particularly in South Asian populations that there might be a little bit less efficacy compared to other populations. But again, the statistical data suggests that there's no meaningful difference at this time.
Well, with that, we're out of time. I want to thank the panel for this terrific presentation. I want to thank the participants in the meeting for spending time in their evening to add to their body of knowledge on the COVID vaccines, and thank the Chicago Medical Society, Dr. Butt, and the entire society, the staff that's put this together for organizing this for the medical community of Chicago. I hope this has been helpful. I hope it has provided you with useful information, and that you will become ambassadors and educators to not only your patients, but your colleagues. This will be available on the website of the Chicago Medical Society. And unless Dr. Butt has a closing comment, I'll thank you and wish you a good evening. Dr. Butt.
Thank you so much, Dr. Andra, and thank you everybody for joining. And thank you, the panel, Dr. Chandi, Dr. Johnson, let's give them a round of applause, and Dr. Lin. And we can bring these great programs to you as Chicago Medical Society president. It's my privilege to invite you to become members if you're not already members. If you are members, renew your membership. And I would encourage you all to become members so we can continue to bring these excellent presentations to you. And COVID-19 Task Force has done a marvelous job. So thank you so very much for joining us tonight. Thank you.
Thank you.
Thank you for having us.